I can start. Okay. So we were starting the mock stations. You can see the topic today, guys. Before starting the mock, I would like to say something about the about our MRCS OSCE exam, the knowledge field. I'd like to tell the knowledge field today. In case of knowledge, you will have station 8 stations and 20 marks each stations, and all the marks are 160 marks, right? So 2 stations from the pathology, 3 stations from the critical care, and 3 stations from the anatomy stations. And I'm emphasizing and telling you that you will have to gain the average pass mark is 108, and that much mark basically fluctuates. That could be 110, 112, or 106, or 105 also. I have seen so many marks, but I think acquiring 115 is the safest one. So you have to fight for 115. If you are enough to gain the 150 in the exam, and I can write you down that you are going to pass in the exam. So on the knowledge stations, the most important stations are the anatomy and the critical care. I am not telling about the pathology because you have to go through so many stations, especially on the pathology, and randomly or new stations come only in the pathology, but not in the anatomy or critical care stations. Anatomy stations are fixed. All the stations are fixed, but you will have to know few new questions, new stations, new pictures. You will have to have a very crystal clear knowledge, especially cadaveric pictures. So these are the fixed stations. You won't get any new stations because our anatomy is fixed. So uh, if you have a very crystal clear knowledge on anatomy, I think it is possible to acquire 50 marks out of 60 marks, right? So after that, on the anatomy stations, always remember that you will get 3 stations, and one station from definitely from the head neck portion, and minimum 1 station from the upper limb and lower limb. That could be 2 stations also, but you will get minimum 1 station from the upper limb and lower limb. And please mute yourself, guys. Who is talking? Please, Dr. Ataur Rahman, please mute yourself. So always remember, you will get the 1 station from the head neck portion, and another 1 station from the sorry. So minimum another station from the upper limb and lower limb. And if 1 station come from the both upper limb and lower limb, then rest of the station will come from the thorax and abdomen. So remember, so always focus on the upper limb, head, neck, and lower limb stations, because you will get 2 or 3 stations only from this portion. Then come to the critical care stations. On critical care stations, you do have a total around 40 stations, and I can assure you that if you do have a very crystal clear knowledge, and you can go through all the stations, all the topics that are written in your book, and if you go through again and again, and if you habituate by telling the answers and do know how to answer the stations, and go through all the skill questions, I can assure you you can acquire more than 50 marks out of 60. So it's also possible. So before starting your preparation, I am telling you right now that the key of success to knowledge portion, this is critical care and the anatomy portion. Then next mock we'll have pathology stations, and we'll say something about the pathology, but not right now, because I'm going to start the mock stations today, right? Is there any question, doctors? Hello, guys. Is there any question? Okay.
Okay, Rifat bhai, I have a question.
Yes, please. Sure.
Okay, brother, no, we are very afraid that the question which was written in our conventional book is the question of the final exam, like something like that or not? or is there any new question?
Okay. Always remember these questions are fixed almost. Especially from the critical care portion, questions are fixed, but pathology stations you will get new questions. So I am telling you that you'll have to have a proper preparation from pathology, but sometimes you'll get so many questions that you won't able to answer. That's why it's a risk zone. So it's better to emphasize the fixed portions from the anatomy and the critical care, right? So almost critical care is totally what is given in your books and what is the given in the recalls. And I am myself and Dr. Hasnat is working so hard for the last 10 and 15 days to make the book so rich, including the skill portions and the new pictures, so that you can guys don't have to go through any other books or any course, any other course, or nothing, nowhere else.
Okay, thank you, brother.
Okay, okay. So we have anatomy stations first. So who was the participant of the anatomy? Who was for the participant for the anatomy? Please, guys who are not participating, please mute yourself. Please, I'm requesting you to mute yourself who are not participating today. So who was for the anatomy? May I know who was for anatomy? Isn't he there? Hello.
Hello,
Okay.
hello,
We can start another statement like
hello.
Who was
Pardon
for
is
the
there.
anatomy? Who was for the anatomy?
I am here. I am here.
May I know your name, doctor?
Afan.
Affan, right. Nice to meet you, Mr. Affan. So, at first, I would like to know, come to the picture one, right? This is your first picture.
Yes.
Could you tell me uh, from which is the side this picture taken from?
It's right side of the thigh.
Right side of the thigh. That's great. Okay. Could you tell me what are the lump that originates usually from the groin area?
It could be septanofemoral
Mm-hmm.
fish, septanobarics,
Verix. Okay. Then.
or it can be inguinal lymphadenopathy,
Okay.
and it could be groin abscess,
Okay.
and it could be a secondary metastasis of the inguinal lymph node from the lower extremity.
Okay. Okay. Come to the next question. Could you tell me what is number B? This one, number B.
It's a femoral vein artery. It's femoral nerve.
Okay, fine. Could you tell me what is number A?
It's sartorius.
Okay, what is number C?
It's femoral artery.
Number D?
It's a branch from the femoral artery, lateral circumflex femoral artery.
Uh-huh. Repeat again. It's a direct branch
Le- le-
from the femoral artery,
it's a
right?
branch from the femoral artery,
And the name?
lateral. Yes,
Name?
lateral femoral
Are you
profunda
sure about
femoris
that?
artery.
Okay, that's great. Okay, could you tell me what is this?
It's superficial femoral artery.
Okay, what is this structure?
It's date cephalous vein.
And what is this one?
It's erector longus.
Okay, could you tell me what is the course of C? What is the course of the structure C?
It's a femoral artery. It's originated from the external iliac artery.
Mm-hmm.
It's a continuation of external iliac artery. And then it's become popliteal artery
Mm-hmm.
at
When
at
it
the upper part
become
of the
without transforming into the femoral artery, it becomes popliteal artery.
and then it's a continuation superficial femoral artery. It's giving its punches and then
Okay,
become
okay, doctor, tell me
super.
when it becomes the femoral artery from the external iliac artery.
As in I think it's could be inguinal after passing the inguinal ligament.
Okay, that's good. Okay, come to the next question. Through which opening does a femoral hernia pass?
Femoral inguinal ring, deep inguinal
Okay.
ring. So super even canal actually.
Femoral hernia. Superficial femoral
Femoral
canal,
hernia,
right?
femoral canal.
Okay, right.
Femoral
Okay.
canal, yes.
Could you tell me the boundary of the femoral canal?
Femoral. Actually, for femoral canal, I've forgotten.
Okay. Is there anyone who can who wants to participate to only for this answer? Isn't there anyone who can tell the answer?
Okay, Dr. Marfa will raise her hand.
Okay, Dr. Marupa, please carry on.
Boundaries of femoral triangle.
No, you are not listening the question. Femoral ring. Just tell me the boundary of the femoral ring.
Superiorly inguinal ligament and laterally পেঁয়াজ আর হচ্ছে
Okay, guys who are not participating, please mute yourself. Please, I am requesting you.
ওদের স্কুবিতে একটু সাউন্ড কমাতে বলো তবে
Dr. Nahid Akhtar, please mute. Okay, Dr. Bublik, please continue. Boundary of the
superiorly inguinal ligament, laterally sartorius, medially adductor longus, and floor is from the iliopsoas, adductor longus, and pectineus.
Is it the boundary of the femoral canal? Is it the boundary of the femoral canal?
Femoral triangle.
Not the femoral triangle, sister.
Sorry.
I am asking for the femoral canal. What is the boundary of the femoral canal?
Can I participate, please?
Okay, sure, please.
Can I say?
Okay, so you're asking about the boundary of femoral canal, right?
Yes.
Okay, so the boundary of femoral canal would be the medial border is formed by lacunar ligament, lateral border is by femoral vein,
Okay.
and and anterior border would be inguinal ligament, and posterior border would be pectineal ligament.
Okay, I think is the easiest way to remember. Just write it down. IPL. I is for the anteriorly inguinal ligament. P for posteriorly pectineal ligament, and L for medially, and that is lacunar ligament. And laterally, that is the femoral vein. Right? This is the boundaries. Could you tell me the importance of the femoral canal? What are the structures that lies in the femoral canal?
There will be lymph of clockwise or something.
Oh, okay, that's good. What is the boundaries of the femoral triangle? What are the boundaries of the femoral triangle, doctor? Please, guys, mute yourself who are not participating. What is the boundaries of the femoral triangle?
Should I answer or the actual participant?
You are the actual participant, right? At first.
No, Dr. Afan was participating, so.
So who was participating from the first? Dr. Arfin?
No, sir. Dr. Afan was participating.
Okay, Dr. Afan, please unmute and continue, please. You are the owner of this station.
So femoral triangle is laterally sartorius, medially adductor longus, above its
which
inguinal
border
ligament.
of the sartorius? Which border of the sartorius?
It's a medial border of the sartorius.
Okay, don't forget to tell this border, right?
Okay, medially it's lateral border of the adductor longus, and above its inguinal ligament.
Medially. I would like to hear again.
Lateral border of the adductor longus.
No, doctor, correct 8. It is also the medial border, right? Then?
Medial border of the adductor longus, yes.
Okay, that's great. Then?
Above is superiorly is inguinal ligament.
Okay, I would like to know especially for the floor of the femoral triangle.
For iliacus, psoas major, and pectineus.
Okay.
From lateral to medial.
Okay. Next, then come to the second picture. Could you tell me which bone is this?
It's a femur.
And which side? And tell me the identifying point of this picture.
It's
Why
the
it is?
right side of the femur.
Okay, why it is
It's
the right side?
lesser trochanter facing lesser trochanter facing forwards, and head is directed medially.
Is it lesser trochanter facing forward?
Lesser trochanter facing backwards.
Okay, that's great. Both the greater and lesser trochanter lies in posteriorly, and the head lies, or the direction of the head?
It's medially, upwards and
Upward,
medially.
medially, and backward, right? Upward, medially, and backward. And
Yeah.
the greater trochanter, this is the lesser trochanter. Always remember this is the lesser trochanter, and it would always lie in the posterior, right? And the most important identifying point of the femur. So, this is the which sided femur, doctor?
It's left-sided.
Is it? Is it? Is it?
Right,
Oh.
right side. Yeah.
Okay, you become confused. Is it right side or left side? Sometimes the examiner will give you some doubts and don't change your answer, right?
It's left side.
Yes. Okay. Could you tell me the structure A?
It's a tip apex of the greater trochanter.
Okay. Structure C
C is a lesser trochanter.
and structure D.
D is the foviola.
Okay. Now tell me the importance of the C. Which muscle is attached with the structure C?
Iliopsoas muscle insertion.
That's great. That's great. You're doing amazing. So could you tell me from where the psoas major muscle originates?
It's a deep fiber originated from the lateral border of the lumbar 1 to lumbar 4 vertebral lateral side of the vertebral bodies, and superficial fiber originated from the thoracic 12 to lumbar 4 vertebral transverse process and lateral surface of the vertebral body.
Okay. Does the muscle insert the lesser trochanter alone? Tell me the whole course.
It's inserted in the lesser together with iliacus muscle.
Then form the iliopsoas ligament, right?
Yes.
Okay, that insert. So tell me the function of the psoas major muscle.
It's a chief flexor of the hip joints.
Okay, that's great.
And
Okay, come to the picture number B. Could you tell me, is there anyone who wants to participate in this anatomy portion? Please raise your hand and I will ask you subsequently because I do have left a few more pictures. So could you tell me which muscle is this?
It's biceps femoris.
Are you sure about that?
It's a semi-membranosus.
Semi-membranosus, right. Could you tell me which muscle is this?
It's semi-tendinosus.
Okay, tell me the inserting point of the semi-membranosus.
Semi-membranosus is anterior surface of the lateral condyle of the tibia. Medial
Semi-membranosus.
condyle of the tibia.
Semi-membranosus. I would like to now know the whole inserting point.
Semi-membranosus is in the lateral condyle of the femur. Tibia, anterior surface of the lateral condyle of the tibia.
Are you sure that, doctor?
And
Is it medial or is it lateral? So which condyle and which condyle lies on which side?
Oh, posterior surface of the medial condyle of the tibia, semi-membranosus. The semitendinosus alongside with sartorius and gracilis is inserted into the anterior surface of the tibia, lateral condyle of the medial condyle of the tibia.
Okay, come to the picture point C. What is C?
It's long head of the biceps femoris.
How many heads of the biceps femoris?
It's a two head, short head and long head.
Okay, tell me the nerve supply of the short head and long head individually. Is the same nerve or different nerves?
Same nerve, tibial part of the
sciatic nerve. Are you sure that? You'll be asked definitely whenever they will give this picture, and they will definitely ask you this question and write it down. They will ask you this question. Okay,
Yes, both are supplied by tibial
is there anyone who
tibial
wants to
parasite.
participate? Who wants to tell the nerve supply? Biceps femoris, nerve supply. Biceps femoris nerve supply. Long head is the tibial nerve, and short head is supplied by the peroneal nerve. Okay, come to the what is number E?
It's tibial nerve.
Okay. Okay. Could you tell me the course of the common peroneal nerve?
The lateral surface of the popliteal fissure. It passes along the neck of the fibula.
Then
It passes to the lateral compartment of the leg. To the
I would like to know
lateral
the
compartment.
divisions
Yes,
of this nerve. I would like to know the divisions because you will have your examination, and these
it's
things are
divided into
so related.
superficial peroneal and deep peroneal. Superficial compartment
Excellent.
passes to the anterior compartment of the leg, and the superficial passes to the lateral compartment of the leg, and deep peroneal passes to the anterior compartment of the leg, and it supplies the dorsum of the first web space of the dorsum of the foot.
Okay, tell me.
Superficial peroneal nerve supply.
Okay, tell me the muscle supplying by the superficial peroneal nerve.
It's tibialis and superficial peroneus longus and peroneus brevis.
Okay, what's the function of the peroneus longus and brevis?
It's an eversion of the foot.
Only the eversion?
Eversion and
Hey guys, who wants to participate, please raise your hand. Or I will ask you subsequently. Just don't be hesitate to participate. We are all here to learn together, and I can say you the best of the best mentors are in front of you. So nothing to worry about. We are here to pass the MRCS OSCE exam together. So nothing to worry about. Just participate and speak out, speak up, because without speaking, you won't able to pass in the exam. So better to do so many mistakes before appearing the exam. So doctor, please continue. So what's the function of the peroneus longus and peroneus brevis? Okay, is there anyone who wants to participate, who wants to answer this one? There is a orthopedician, Dr. Mosharraf is here. I would like to hear from Dr. Mosharraf. Could you tell me? Okay, isn't there anyone who want to participate? Is there Dr. Bubli is here?
Yes, yeah.
Okay, so why aren't you speaking? So what is the function of the peroneus longus and peroneus brevis?
Yeah, peroneus longus and brevis both are doing eversion, and especially peroneus longus abduction.
Okay, tell me the inserting point of the peroneus longus.
It's in the medial cuneiform at the base of the first metatarsal, alongside with
Peroneus,
medial
exactly.
cuneiform bone.
Base of the first metatarsal, laterally or medially?
It's medially.
Peroneus longus. Are you sure, doctor, that lies in the medially?
Sorry, it's lateral. Tibialis anterior is medially.
That would be any answer, whether it would be medial or lateral, right? Okay, no problem, guys. So what is number D?
It's shorter of the biceps femoris.
Are you sure?
It might be.
Okay.
Yes, it's biceps femoris.
No, doctor, it's quite difficult, and that is vastus lateralis, right? Okay. Okay. Come to this picture. Come to this picture. Could you tell me which structure this one? Number A.
Is it popliteal fossa?
Yes, this is wholly popliteal fossa. I would like to know the number A.
Okay, it's It could be sural, no, sural nerve. No, it's muscle. Semitendinosus.
Yes, that's great. This is semitendinosus muscle. Could you tell me structure B? What is structure B? This one.
It's popliteal vein.
Okay, excellent. You're doing really great. Could you tell me what is number C? And deepest structure is the deepest structure of the popliteal fossa.
Popliteal artery.
Excellent. Could you tell me the structure E?
It's a small saphenous vein.
Small saphenous vein. Okay. So could you tell me the nerve that is closely related to small saphenous vein?
Sural nerve.
Okay. Okay. Would you tell me the lateral head? Sorry, I am telling you. What is the structure F?
It's a lateral head of the gastrocnemius.
Okay, that's great. Okay, now tell me the what is picture is?
It's A is popliteal artery.
Mm-hmm.
And B is
I would like to know the picture of this one. Then I'll come to the
it's
individual.
okay. It's angiogram of the lower limb.
Okay,
Angiogram of the leg, lower limb.
that is the full name would be, they would like to know the full name, digital subtraction angiogram.
CT angiography of the
Digital
yes.
Digital subtraction of angiogram of right lower limb. This is the whole full answer, and unless you tell the full answer, they will keep asking you, right? So could you tell me what is
Yes.
number A? What is number A?
It's popliteal artery.
Which sided? Right or left?
It's a right-sided.
Exactly.
Right-sided popliteal artery.
Okay, now tell me the structure B.
It's an antiotibial artery, right-sided.
Exactly. Structure C.
It's a posterior tibial artery.
Very good. And structure D.
It's a peroneal artery.
Excellent. Excellent. Now come to this picture. Rather, I would like to ask you this one. Okay. Could you tell me what is number E?
Is can you tell us?
Mm-hmm.
Tell us.
So why are you so confused? You are answering every question so perfectly, but you are saying confused with so many confused. Guys, I would like to say one thing, that after seeing, if you go through the mark distribution of the knowledge portion, and you'll be surprised that there is so many marks other than the answering the perfect any questions perfectly, because there is a number that is called professionalism. And if I ask any questions, and if you tell me so with so many confused, like the doctor is saying every single question so perfectly, and he is answering everything, but the way of the presentation and way of the answering is a little bit confused. Oh, he's doing perfect, but like just notice the last answer, he was just saying this is the tell us, like he's asking me whether it is tell us or not, but it's not the professionalism, so you lose some marks. So overall for the whole MRCS exam, you will get 48 or 47 marks only from the professionalism. So you have few marks on the knowledge portion also, half of the professionalism from the knowledge portion also. So if you can answer the questions smartly, you won't be able to pass in the exam, and that will lose you some mark, right? So try to answer again and again in a very smarter way, so that you make you pass easily. Okay, doctor, did you get my point?
Yes, sure.
Okay, doctor, come to the picture A, point A. What is this?
It's head of the fifth metatarsal bone.
Okay, so what is B?
It's intermediate cuneiform bone.
Okay, what is C?
It's a navicular bone.
Okay, that's good. What is D?
It's a medial cuneiform bone.
Okay, I do have so many questions from this portion, but we are lacking of time because it's taking so many times just come to this picture. Okay, could you tell me what is number A, 17?
70 is anterior.
Okay, now tell me the inserting point of vestibular anterior.
It's in the base of the first metatarsal bone alongside with medial cuneiform bone medially.
Okay, what is the function of the tibialis anterior?
It's a dorsiflexion and inversion of the foot.
Inversion and dorsiflexion, right?
Dorsiflexion.
Could you tell me the nerve supply of this muscle?
Deep peroneal nerve.
So what will happen if deep peroneal nerve become injured?
Foot drop. Foot drop. For motor loss, it will be foot drop. Loss of dorsiflexion, and for sensory, it will be loss of sensation over the first web space.
Okay,
Dorsum
that's
over the
great.
first
That's
web space.
great. Okay, tell me what is number 7?
It's extensor hallucis longus tendon.
Okay, tell me the relationship with the arteries dorsalis pedis with the extensor hallucis longus.
It's just lateral to the extensor hallucis longus at the first web space of the metatarsal.
Okay, so what is the most appropriate point to feel the arteries dorsalis pedis and tell me the relation?
It's in the first metatarsal space, base of the first metatarsal space, just lateral to the extensor hallucis longus.
And against the navicular bone, right? Okay, tell me
Yes,
structure
against the navicular.
6. Structure 6.
It's extensor hallucis brevis.
Okay, okay, okay. I don't have anything to ask here. Okay, that's great. Doctor, what is your name, doctor? Dr. Affan, right?
Affan, yes.
Where are you from?
I'm from Silet.
Okay, that's great. Okay, you did very well in the whole station, but I do have so many pictures, and especially I have collected from whenever I went to Malaysia, and I collected from an Egyptian, and I do have so many pictures, but I couldn't show you because I do have some lack of time because we do have so many things to practice today, and I'm so sorry for that. But one thing I would like to mention is that you did very well in the whole station. Throughout the station, you did very well, really. And just improve yourself by saying again and again smartly and build your professionalism. Nothing else. Just go to the pictures because you won't get any known picture in your exam. Just have a proper orientation so that you can identify the pictures so perfectly, right? Thank you. Thank you for your participation.
Yes. Okay. Thank you very much.
Okay, well. So is the critical station? Who was there for the critical station? Who was for the critical care, doctor?
Hello.
Hello, who is this? Dr. Nashid?
Yes.
Is it Dr. Nashid?
Yes, I am.
Okay, I can hear so
Hello.
properly. Would you please make your voice clear and bring your mic in front of your mouth? Okay, you do have
Okay.
1 minute. Basically, I would like to tell you the scenario. Like this is a room, and this is a door, and in front this is Dr. Nashid. This is Dr. Nashid, and you will get 1 minute to read out the question in the pathology station, and in front of the door there will be question. And especially pathology stations questions are so long, almost it will cover all the page, and you will get only 1 minute to read out the question. Then they will ask you to enter, the bell will ring, and you will have to enter into the room. Then there will be a table here, there is a chair here, and the professor is sitting here. This is the professor. So whenever you will enter into the room, so what the most difficult situation that arises here, because that is the time. You will get only 1 minute to read out the question, and they will give you so many information in the question paper, and you'll have to read out the question only 1 minute. And whenever you will come to the sixth or seventh line will be, forget the first or second line eventually. So I would like to tell you that just relax and read the question properly. If you can't read the question properly, don't start answering the questions. This thing won't say, there is nobody who will say about this thing, but this is the most important difficulty you face in the critical care station at first. No, I have seen so many mentors, so many doctors who talk about me critical care sessions, but every one of the doctors who appeared in the exam faces this problem, have faced this problem, but nobody won't send you. So I'm telling you today, just remember, this is the first obstacle you'll face in the critical care. So always just relax, read the question properly. If you can't read the question, nothing to worry about. There's another question paper in front of you table and in the professor. So as soon as you enter into the room, your consultant will ask you whether you have read out the question or not, or you would like to read the question. So if you can't, if you have forgot everything, that because you are so nervous and by standing down, you couldn't understand the question what is saying, you even couldn't understand what the station is, so it would be much more difficult for you to answer the question properly. So my first advice to read the question, and if you can read the question, then ask your professor again, sir, would like to read the question again, and he will offer you. And if you read the question for long 4 or 5 minutes, they won't bother you because you are losing time. So I would always say utilize your time smartly. Just relax and read the question properly, and find the final diagnosis, because all the stations you'll get in the critical care, they will be your known questions, so nothing to worry about. Okay, Dr. Nashid, you do have 30 seconds to read the question, then we will start.
Okay, I am ready.
Okay, Dr. Nashid, could you tell me what is the diagnosis?
Okay, this is a case of obstructive jaundice.
I didn't get you.
This is a case of obstructive jaundice.
Okay. In what form does bilirubin circulate within the plasma?
Bilirubin circulates in plasma in both conjugated and unconjugated form.
Okay. Why clotting factor decreased?
Because of biliary obstruction, there is several liver damage, and liver synthesis most of the clotting factor. Also, there is decreased absorption of the vitamin K and vitamin K dependent protein factors like C7, 9, and 10.
Okay, that's great. Which clotting studies may be abnormal? What are the investigations that may be abnormal?
Secondary type and INR.
Both time and INR. So how to correct clotting abnormalities?
By giving intravenous vitamin K and also serum plasma and prothrombin complex constant.
Okay. So any other investigation we would like to go for?
Yes, abdominal ultrasonogram.
So what do you expecting from the abdominal ultrasonogram?
Dilatation of the intrahepatic and extrahepatic biliary stent.
Okay. So so if you find a CVD stone, so what is next step?
I will go for ASSCC.
Okay, could you tell me the function of the bile?
Okay. Bile helps in fat absorption by emulsification of the fat and formation of maculi formation, and increasing the surface area of the fat globules so that the pancreatic lipase over the.
Okay, could you tell me the constituents of the bile?
This is formed by water, then cholesterol, and the bile salt, bile pigment, and
I would like to
small
know
amount
the
of heavy metal.
proportion of the water. I would like to the percentage of the water in bile.
It's about 95%.
That's about 97.5%. Okay. Then what are the things that present in bile?
bile salt, I cannot remember the percentage of the bile salt.
Okay. Then what are the other constituents of the bile?
Cholesterol, bile salt, then bile pigment like bilirubin, biliverdin, and some amount of heavy metal like copper.
Okay, could you tell me what is biliverdin is?
Biliverdin.
Yes, you mentioned that there's a biliverdin in bile, so I would like to know the what is biliverdin is.
After hemolysis, hemoglobin is converted to biliverdin by the enzyme of heme oxygenase, and which is converted to bilirubin.
I didn't get you again, please.
After breakdown of the RBC, the hemoglobin is converted to biliverdin, which by the heme
Directly,
oxygenase.
does the biliverdin directly converted from the hemoglobin? Okay, I will come to this point later. Please remember me. Oh, okay. How do bile salt help in emulsification of fat? How bile salt help?
Bile salt has a hydrophilic and hydrophobic portion. The hydrophilic portion remains inside of the micelle and binds with the fat globules, and the hydrophobic portion remains outside the micelle, and it helps in transportation of the fat globules and uh, prevent the fat globules to aggregate.
Okay, so what's the advantages?
That helps in transportation of the fat in the water soluble medium.
Is it the only advantage of the bile salt? Is there any relationship with the pancreatic lipase?
Yes, it increases the surface area of the fat globules and the pancreatic lipase enzymes over the globules.
Okay, I think the concept is not crystal clear because this portion comes very fast other than that you have mentioned. So could what is bilirubin conjugated to and how it become conjugated?
By the glucuronic transferase enzyme is conjugated to glucuronic acid.
Uh, Glucuronic acid conjugated, it basically conjugated with glucuronic acid and converts into conjugated bilirubin, right? And what the site?
At the liver.
Okay, so tell me what is the most important difference between the conjugated bilirubin and unconjugated bilirubin?
Okay, unconjugated bilirubin is lipid soluble and conjugated bilirubin is conjugated
So
bilirubin is
what will happen if unconjugated bilirubin is markedly increased in blood?
okay, it will cause the blood-brain barrier and it will cause the blood-brain barrier
Okay,
and
that's great.
causes
Okay, could you tell me the fate of RBC?
okay, RBC after crossing the half-life 120 days, RBC is broken down into heme and globin. Heme is then converted. Heme is converted to the globin is entered the amino acid pool, and the heme is then broken down into biliverdin. Biliverdin is converted to bilirubin.
Biliverdin and so you're saying that okay, then what happens?
Okay, then biliverdin is converted to bilirubin, and bilirubin binds with the albumin and enter the hepatocyte where it is conjugated with glucuronic acid by glucuronic transferase, and the conjugated bilirubin is excreted with bile into the second part of the duodenum, from where it enters into the small gut, and at the terminal ileum, the bile salt is absorbed and by intrahepatic recirculation, and the bilirubin is entered the colon where it is deconjugated by colonic bacteria and converted to urobilinogen.
Okay, tell me what
10% of the
is
urobilinogen
urobilinogen and how it is formed?
is the byproduct of the bilirubin metabolism, and it is formed by the colonic bacteria at the last part.
So there is a one point that is urobilinogen is undetectable in urine. So why it has happened?
In case of obstructive jaundice, when bile cannot flow, urobilinogen is undetectable in urine.
I didn't get you.
In case of obstructive jaundice, when the bile flow is obstructed, urobilinogen is undetectable in urine.
So you have skipped so many steps, right? Because it at first goes to the second part of duodenum, that it uh, broken down
Okay.
into through the bacteria urease, and it breaks into urobilinogen, start to urobilinogen again, absorb, then it goes to the urine. So these are the steps you have missed out, right? Uh, uh, what is the complication of the reduction of bile salt in the small intestine? What will happen?
There will be fat malabsorption or steatorrhea, and also malabsorption of vitamin K dependent protein factors like fat soluble vitamin like ADH. And
ADEK, right? So what do you mean by sepsis 6? Could you tell me what is sepsis 6?
sepsis is the protocol of sepsis management where we keep free and take free from the patient. We will give hyperoxygen to maintain the saturation of more than 94%, and we will give the patient intravenous fluid for resuscitation and intravenous antibiotics for control of the sepsis, and according to trust protocol, and we will take blood for blood pressure, and we will take blood for blood pressure and CBC, and we will take we'll also take blood for serum lactate, and we will catheterize the patient to monitor hourly urine.
Okay, that's great. Dr. Nashid, you did really well, and you are like a pro. You answered so many questions so perfectly, but I would suggest you to raise your voice and become so clear so that everyone can understand you are answering with your whole pace and the confidence. So that's great. Is there anyone who has any confusions regarding all these questions? Even asked me, and I think Dr. Nashid do have a lacking of fate of RBCs and the consequences, especially the consequences, what will happen after entering into the small bowl. So whenever I will get some time, then I will discuss you, because we are lack of time, because we do have so many things to discuss, right? So let's come to the second critical station. Who was the participant for the second stem?
Dr. Rifat bhai, I would like to participate.
Okay, you are the second one, and as far as I know, there is another one who wanted to participate.
I am here.
Okay, Dr. Kaushik, you are for this portion, and I think I will cover this station with Dr. Sulaiman and Dr. Kaushik, right? So at first,
Okay.
I would like to give the platform Dr. Kaushik, then I will ask question Dr. Sulaiman. So Dr. Kaushik, you do have 1 minute to read out the question.
Okay. Okay.
Okay, are you done, Dr. Kaushik?
Yeah.
Okay, could you tell me what is the cause of the low urine output of this patient?
Regarding the history, I think this is the inadequate fluid in perioperative and postoperative period. So there is a decreased uh, volume, intravascular volume that leads. Hello.
I am listening, you, doctor. Please continue. Please
Yeah,
continue.
doctor. So there is a increased intravascular volume due to inadequate fluid management in perioperative and postoperative period.
So one thing, I don't know whether Dr. Nashid is here or not, but I would like to say one thing that in your case, whenever you read out the scenario and I ask you the what is your diagnosis or something else, so always remember your professionalism, the marks that are written for your professionalism. These are the stations and these are the points where you have the marks for the professionalism. So Dr. Nashid directly said that is obstructive jaundice, but if she could say, considering the age of the patient, 45 years, and patient is having episodic pain, nausea, vomiting, and patient, the most important finding is patient's dark urine, and investigation is urobilin absent or undetected urine, and that's why considering these findings, my diagnosis of obstructive jaundice. So this is the way how to answer. Dr. Nashid, are you here? So your professionalism are kept for this station. So never go directly the answers, because you will have to, you are discussing a case or a finding with a consultant. So whenever you will directly say this is a obstructive jaundice, that seems that you know everything. But don't do this at first. Tell the positive points why your diagnosis is, just mention 2 or 3 words. That is not important, but you will always have to mention the most important findings that are given in your scenario, right? So these things will bring you some marks, I think. And you, whenever you go through the your answer script or your mark distribution, or the I'll share a file in our group, so you'll able to know that how many marks that are kept for the professionalism. And I always say, one of my elder brother attempt with me, and he's a fellow, of course, and he's a fellow and he has so many DECI degrees, and he's a consultant, and he only achieved in the skill portion only 90 out of 180. And as far I remember, I got 143 or 44 in this portion, and he was so excellent, but he gained only 90 marks. So he was just asking me, Dr. Rifat, how do you get so many marks in this portion? So I just met him and I asked him, "Bhai, did you do this? Did you do this? Did you do this?" And he didn't do anything, any of this. And after having the mark sheet, he come to know that he gained almost less than 50% mark in the professionalism. So this is the most important thing all of you will able to answer, because all the questions and the scenario are the fixed, so you'll able to answer this portion very perfectly if you read out and if you read properly. But until and unless you come know this, the mark distribution or the way how to answer, you won't find the marks in the professionalism, right? So give emphasis on this portion. So Dr. Kaushik, come to you. So could you tell
Yeah.
me again, answer the what is the cause of the low urine output?
Uh, yeah, doctor. Yeah, I already told that regarding the history and uh, giving finding is the cause is there is inadequate fluid management in perioperative and postoperative period.
Okay, basically patient is being persistent hypotension and tachycardia, and you can
Yeah.
come to know there's only two fluid challenge and nothing in between is given. So this is the fluid is given, that is not adequate for this patient. So that might be uh, the cause, right? So is that adequate?
No.
Okay, Dr. Kaushik, could you tell me how would you manage this patient?
Uh, I will give I will give him a fluid challenge, that is 250 ml bolus dose or 10 ml per kg, and monitor and continue monitor the response of the patient.
Okay, that's great. Okay, tell
by
me,
seeing
what is dynamic fluid response?
uh, uh, if dynamic if we give the patient, if we give the fluid to 50 ml IV bolus, there is a raise of BP. I mean, there is a give a response with the fluid challenge. This is called dynamic fluid
Is it
response.
Anyone who can participate and answer perfectly? Dynamic fluid response and the type of dynamic fluid response. Guys, just go to the belly lab, and this is the most important topic, and you will have in your stations, especially phone call stations and critical care, so many critical stations, you will have this thing from the dynamic fluid response. And always remember, dynamic fluid response is 250 to 500 ml of the crystalloid, and that is given within 5 to 10 minutes. And always there are some vitals are seen. These are the heart rate, blood pressure, and central venous pressure. And this dynamic fluid response is divided into three groups. One is responder, and another one is transient responder, and another one is non-responder. So dynamic fluid response have two functions. One is diagnostic and another one is therapeutic. Now come to the question. Whenever I'll get some time to discuss with this, I'll get some time, I will definitely discuss with you. So will you tell me why would you give fluid challenge rather than speeding up the jeep?
Because by giving the fluid channel challenge, there is a stretching, there is a increase the volume of intravascular compartment, and there give a stretching over the heart chambers. So we take the benefit of Frank-Starling law. So we can we can get the benefit. By that, taking this benefit, we can raise the BP of the patient.
Okay, tell me the main concept of the Frank-Starling law.
When the more the stretching of the muscle, the more the cardiac contraction. So increase the cardiac output and increase the BP.
So that means the force of contraction is directly proportional to the length of the cardiac muscle fiber, right? Within the physiological limit, right? That's great.
Yeah.
How to manage this patient after fluid challenge, or what the things will have to see in your shift? How will you monitor the patient?
I will monitor the blood pressure, pulse, and capillary refilling time, and urine output also.
Okay. Then?
And
okay, like you kept this patient in the ward, and you left the patient in the ward, and the duty nurse is continuously monitoring the patient, right? So what are the instructions you are going to give the duty nurse? When to call you?
I I give instruction to nurse that when the this BP is fall or pulse rate is increased or there is no response, and if evidence of any occult blood loss, then he called me.
Okay, doctor, come to the another question. So how many times does the dynamic fluid response can be repeated?
How many times?
Yes.
Dynamic pass, sir.
Is there anyone
don't
who would
know
like to
this
answer, participate? Is there anyone? Yes,
Yes,
please.
4 times. 4 times.
Yes,
2 fluid
yes,
challenges.
yes, four
Maximum 2.
times. No, doctor, that the 4 times. 4 times. Dynamic fluid response can be repeated for the 4 times, right? Not the 2. So what your job to do if the fluid response is not responding, Dr. Kaushik?
If there is no response, then I will inform my consultant and also shift this patient to SDU to do the CV central venous line, and uh, I will continue the monitoring of central venous pressure.
Okay. So how would you calculate the blood pressure? How blood pressure is calculated basically?
Um, Blood pressure is calculated.
It is the equation of
equation of cardiac output and to heart rate.
And cardiac output, the equation of? Okay, this question won't be asked in your exam. So, Dr. Kaushik, I would like to come to Dr. Sulaiman. Dr. Kaushik, you did very well. There are a few more questions are left. I would like to come to Dr. Sulaiman. Are you there, doctor?
Yeah.
Okay. So, would you tell me that are the stress hormones that are increased in any stressful condition?
Okay, there are several hormones that increase during the time of stressful condition, like from the pituitary gland, there are the growth hormone, adrenocorticotropin hormone, prolactin, and also the ADH, glucagon during the time of any stress, and also the aldosterone, cortisol, and renin also increase during the time of stress.
Okay, and what are the hormones that are not changed in stressful condition?
Okay, the unchanged hormone are the thyroid stimulating hormone, follicle stimulating hormone, and luteinizing hormone.
And what are the hormones that are decreased in stressful condition?
Decreased are the insulin, testosterone, and also the estrogen.
Okay, so could you tell me how ADH is stimulated, from where it is produced and from where it is released, and how it acts?
Okay, ADH is stimulated during the time of when the body is in hypovolemic condition, or when there is a increase the osmolarity of the plasma, or when there is a increase the level of the angiotensin 2, and it is synthesized in the or produced in the posterior in the hypothalamus, and from the hypothalamus it is transported and stored into the posterior pituitary gland, and from where it released during the time of necessary.
Okay. So you left the last one, how it acts.
Okay, it acts on the collecting duct of the nephron, and it stimulates to release the aquaporin 2 on the apical membrane of the cell of collecting duct, and from where the solute-free water are directly reabsorbed from the lumen to the interstitial space and then come into the blood.
So just correct your answer, and it is written in your book that the exact site of the functioning of the ADH is the late distal conduit to collecting duct, right? And it is the reference of Gannon. So could you tell me by which mechanism does ADH facilitate uptake of water from the tubular fluid? You have already mentioned, but I would like to hear this answer again.
Okay, when ADS act on the cells of the collecting duct or distal portion of the distal convoluted tubule, it releases the aquaporin 2, that means the water channel or protein, and this protein are sits on the apical membrane of the cell of collecting duct. And from this channel, water, solute-free water are transported or reabsorbed from the lumen of the nephron to the interstitial space and then come into the blood.
Okay, that's great. So could you tell me how countercurrent mechanism works
Yes, the counter current mechanism works basically in the loop of Henle, and the descending part of the loop of Henle is only permeable for water comes from lumen to interstitial space, so that the glomerular filtrates become hypertonic in the lumen of the nephron, and when the glomerular filtrates pass through the ascending limb of the loop of Henle, this ascending limb causes the active secretion of the sodium from the glomerular filters, that means from the lumen to the
Active
interstitial space,
secretion,
and
active secretion or active reabsorption?
active reabsorption from the
So could you tell me the
ascending
channel?
limb.
What is the name of the channel?
Yes, the name of the channel is sodium potassium 2 chloride channel.
Okay, could you tell me which diuretics works by binding this channel?
Yes, furosemide diuretics bind in this channel.
And could you tell me what is the percentage of the sodium that absorbed by this way?
Approximately 25%.
That's great, very good. What are the complications of the furosemide?
Okay, it causes the both hypokalemia as well as the hyponatremia and hypochloremia.
Anything else? The most important components you have mentioned missed? Those are the hypomagnesemia and hypocalcemia, right? Could you tell me the function of the aldosterone?
Yes, aldosterone act on the distal part of the distal convoluted tubule and also the collecting duct, and it binds with the receptor on the cell of the distal convoluted tubule, and then it causes the reabsorption of the sodium and
Always
along
guys,
with
always
water.
guys, I would like to correct you because these things are written in your book, and always remember that allosterone ADH always works on the late distal convoluted tubule. So don't say by this the as a term like distal convoluted tubule. Always, principally these cells are there is two type of cells that are present in the chitin duct. One is intercalated cell, another one is principal cell, right? So these cells are responsible to bind for the aldosterone and ADH, and these are the mainly responsible for maintaining of the acid-base disorders of our body. So answer like this way, and I would request you because this station really it commonly comes in your exam and you will very commonly find in your exam. So the things that are written by several writers, but those writers or those mentors only collected the question, but they didn't collect the answer. That's why with the answer the examiner are not always satisfied. So I would request you, I'm correcting so many answers in our books. So is it feasible to you? You can collect the books because we are trying to correct the answers. But especially those the stations, especially I kept these two stations. You, if you go through the last year recalls, you will come to know that these stations very commonly came in the exam. That's why I kept these stations. So try to correct these things. Aldosterone ADH only works on the late distal convolutive onwards, not the whole distal convolutive, because early distal convolutive is a very tight junction and it is totally impermeable to any kind of water, right? Could you tell me the function of the angiotensin 2, Dr. Solomon?
Okay, yes, the angiotensin 2 has several functions. It directly acts as a vasoconstrictor,
I would
and
like
it
to
also causes.
five functions in a row. I'd like to five functions in a row.
Okay, it causes the stimulation of the sympathetic nervous system. It causes directly vasoconstriction. It also stimulates the aldosterone from the adrenal cortex, and also it causes the release of the ADS from the posterior pituitary, and it also has a negative feedback on the baroreceptor.
Okay.
Is this five is enough?
Okay. It also stimulates the release of ADH, aldosterone, vasoconstrictor,
Yes.
and you have
Constrictor.
forgot to mention that it increases the absorption of the sodium from the proximal convoluted tubule. Okay.
Yeah.
Okay, I
Yes.
think we have covered almost all the questions from this station. Okay, I would like to
Okay.
answer this. Dr. Solomon answered almost every question so smartly, and my friend Dr. Kaushik also answered the stations so perfectly. But one thing I have forgotten, Dr. Kaushik, you will have to answer the question smartly. Like Dr. Afan, you are so confused in the answering the questions, but you, both of guys, you did very well. Just you'll have to improve and by practicing again and again. But in case of Dr. Solomon, he did very well. But one thing I noticed that he's like uh, uh, just copy printing from the books directly. So I think he read everything very perfectly. But just remember, you will get so many questions by so many ways. Examiner will ask you if time permits. He will ask you so many things, especially critical care portions. So you'll have to crystal clear knowledge, you'll have to surrounding knowledge whether it is correct or not, so you'll have to look for this answer. So I would ask Dr. Solomon another one. Why would you give fluid challenge rather than speed limit? Please, you can explain.
Okay, the fluid channel has both two purpose. One is the diagnostic purpose, and another is the therapeutic purpose. If we give the fluid channel, it increases the volume of the blood, and as well as it causes stretch of the left ventricle. And according to the Frank Starling law, if the left ventricle is stretched more, it causes more force of contraction and increase the cardiac output. But in case of the fluid, if we give the fluid in drip, it will not causes the any it will not give any diagnostic purpose for the patient.
Okay, thank you very much, Dr. Solomon. You did very well. Keep in touch and practice again and again. If you continue this way, you'll definitely pass in the exam, inshallah.
Thank you.
Okay, that's great. All the three
Thanks so much.
participants or four participants in the previous stations, everyone did very well. Now come to the history taking stations, our first stations. Who was for the first stations? I think this one is for the dye worker. So this is
Yes,
the hematuria. So who was for the hematuria?
it's me,
Who is this? Please mention your name.
Marufa.
Okay, that's great, Dr. Marufa. Uh, okay, is there anyone who want to be the patient so that I can notice her mistakes? Is there anyone who want to participate and become the patient? Isn't there anyone who who want to be a patient? Dr. Shubha? Okay, I would request you, someone, Dr. Kaushik, just be the patient. Hello?
Hello, sir. Sir, I'm sorry to interrupt. Actually, about the previous station, the previous candidate mentioned something about some 25% absorption, something you mentioned. I could not understand.
There's
Could you please
that's
elaborate that?
there's the total sodium. Can you see the picture? This is the nephron. This is the nephron. This is the
Okay.
nephron, right? So
Okay.
nephron, almost all the sodium that comes into the nephron, almost maximum amount of sodium become reabsorbed. So almost 65% sodium is reabsorbed from this portion, that is proximal convoluted tubule, and this portion doesn't reabsorb any kind of source. This portion only responsible to reabsorb the water, and from the
Only water.
thin ascending limb of loop of Henle to early distal convoluted tubule, there is a channel that is called sodium, potassium, and 2-chloride. And by this way, 25% of the sodium is reabsorbed by this way. And fusamide works by blocking this channel. And we are just
Okay.
discussing about this thing, right?
Okay.
Did you get it? Okay.
Yeah. Thank you so much. Thank you.
Okay, welcome. No worries, guys. Okay, Dr. Kaushik, are you there? Isn't there anyone who want to participate with the history taking? And as I am from a background of the urology, so I become the I would like to become the patient.
Actually,
Okay.
Dr. Rifat, I am in duty actually.
Okay.
So I have
Okay.
to take an intermittent break for 5 minutes.
Okay. No
And
problem.
I am again jogging.
Okay,
Okay.
Dr. Solomon, would you like to become the patient, or I can? Would you like to?
I would like to be examinee. That means a candidate.
Okay, candidate has already been fixed, so you can become
Okay.
the patient. You can become
Okay,
the
I
patient.
can.
Okay, Dr.
Okay.
Marfa,
It's
you do
okay.
have 1 minute to read out the question. So I have already
Okay.
mentioned you in the offline mock that I have taken in the BSMO. In case of history taking portion, in the skill portions, there are. Do you know how many skill portions are there? How many stations? 9 stations,
9.
right? 9 stations.
Stations.
3 for the examination, clinical examination. 3, 2 for the history taking. 2 for the procedures, and what are the left? And 2 for the communication. So these are
Communication.
the 9 stations. So for the skill portions, the most important place to find the mark, these are the procedures, and 2 are the history techniques, and these are the most important stations. All the marks are kept for you to give you in the exam. And I have seen so many examiners and so many students who got 18, 19 marks out of 20 marks. So these are the places. If you are well prepared, you are able to find all the marks in this. And I can assure you that, and I can very confidently say that I almost found 37 or 38 out of 40 marks from the history taking. So these are the most important place to have the mark. So don't overlook, just don't say the history takings are very easy. Don't overlook the stations, because as much as you practice these stations, your percentage of passing the will be increased. Right. So Dr. Marufa, are you ready? Dr. Solomon
Yes, sir.
is ready to become the patient. Okay. So uh, your time is starts right now. Start your history taking.
Okay. Hello. I'm Dr. Marfa, one of the exam candidates here. May I confirm your name and age, please?
Yes, I'm Alex, 6 years old male.
Okay. Nice to meet you, Mr. Alex. Today I have been asked to ask you some question regarding your condition. Are you okay with this?
Yes, you can.
Okay. During our conversation, I am going to write down some important notes. Are you comfortable with that?
Okay, it's okay.
Okay. Mr. Alex, how can I help you today?
Oh, doctor, I am passing some red urine for last 2 to 3 months, and it gives me so pain, and I'm so worried about it.
Oh, I'm so sorry, Mr. Alex. I'm really sorry to hear about it. Uh, can you please tell me when did you first notice this?
Oh, approximately 2 months back.
Okay, I'm writing it down. And can you please tell
Yes.
me, is it present when you only pass urine?
Yeah, most of the time along the urine.
Okay. Is there any chance that it could be come from elsewhere?
No, I'm not noticed about that.
Okay. Can you tell me about the color? Is it dark or red?
It is red in color.
Okay. And can you tell me when did it started? Did it started gradually or suddenly?
It started gradually from 2 months back.
Okay. And have you recently eaten some deep fruits or like reddish fruit?
No, I have not eaten something like that.
Okay. And does it come and go or get previously worse?
Now it is progressively worse.
Okay, I'm sorry for that. And is there anything that makes the bleeding stops?
No, the bleeding occurs just only when I go for pee.
Okay. Or is there anything that makes it increases?
No, during the time of pee, just only that time I have noticed it.
Okay. And is it present at the start of your urination or at the midstream or at the end?
No, not like that.
Do you pass any clot?
Yes, I have noticed some time that some clot has already passed with my urine.
Can you tell me how is your appetite recently?
Oh, for the last 1.5 months, I have lost my appetite and I am not able to take my meal properly.
Okay, I'm writing it down. Have you noticed any unintentional weight loss?
Yes, I think that I might lost some weight because my clothes are become loose for nowadays.
Can you please mention that how much you lose in how long?
I have not measured, but I think that it approximately 4 to 5 uh, kilogram, maybe.
Okay, that's great. Do you have any back pain or any pain in your tummy?
Yes, I have noticed some back pain for last 1.5 months.
Okay, and can you please tell me, do you have any pain when you pass urine?
Initially, there was no any pain, but for last few weeks, I have noticed some pain during the time of access my pee.
Okay. Have you noticed bleeding from any other orifices of your body?
No, other orifices are okay.
Okay. Do you have any problem that you have to rush to the loo?
No, it is normal.
Are you able to hold your urine?
Yes.
Okay. And do you have to wake up at night to go to the loo?
It is normal as usual, like one time is normal, I think.
Okay. Have you had any injury or trauma in your tummy or in your groin area recently?
No, no trauma.
Okay. Do you have any medical conditions or have you undergone any surgeries?
Yeah, I have done a surgery approximately 5 years back for my appendix. It was.
And are you taking any medications or you are allergic to anything, any medications or any food?
No, regularly I don't take any medication.
If you mind, if you don't mind, then I can ask you some personal questions.
Yes, you can.
Okay. What do you do for your living?
Okay, time is up.
I work in
Dr.
a factory.
Dr. Marfa, your time is up.
Okay, Mira.
Okay. So, would you like to tell me the positive finding or present your case?
I want to say the positive finding.
Okay. Tell me the positive finding.
Okay, Mr. Alex, 66 years old, presented with hematuria, which was initially painless, but for the last 2 months, he noticed he feels pain, and he also has a history of back pain, and he is a dye worker, and he has no abnormality in his urine stream, and he has no abdominal pain or any loin pain. So based on these findings, my provisional diagnosis is bladder cancer.
Okay. The position diagnosis is bladder cancer. So, what are the investigations you would like to go for?
Okay, I want to do urine depistic test for detection of the blood, and also urine is sent for cytology. and I want to do some blood investigation like full blood count, urea electrolyte, and coagulation profile. And I also want to do ultrasonography and also the CT scan of the abdomen and pelvis,
Is it contrast or
and
non-contrast?
also cystoscopy. If the renal function is normal, then I can go for contrast.
Okay. So how would you confirm your diagnosis?
By cystoscopy with biopsy.
Okay. So how would you treat the patient?
Okay, I will discuss it multidisciplinary team approach, and and it depends on the staging and grading of the tumor. And I can go for transurethral resection of the bladder tumor or radical prostatectomy, or I can give him conservative management like chemotherapy, immunotherapy, and radiotherapy.
Could you tell me on which type of patient you would like to go for transurethral resection of the bladder tumor, and on which cases you would like to go for the radical cystectomy?
Sorry,
Is there anything you would like to add with the TURBT? Is there any
yeah,
immunotherapy or
I can,
chemotherapy?
yes, yeah, I can installation of chemotherapy or vaccine therapy. So the
Could you tell me the name of this thing?
BCG vaccine.
Okay, that's great. And any other thing? Okay. Okay, not needed. Just if you could only mention that I would involve the urologist, that's all, because it's not your work to do with the BCG vaccine or intravesical mitomycin or something else. But always remember, in case of non-muscle invasive, just try to answer the question so smartly, because they will definitely ask you the questions how would you manage the patient. So definitely you, in any kind of malignancy cases, you will have to start with your answer like this, or I would like to treat the patient with multidisciplinary team approach is the first point. Then if they ask you a few more things, then if the tumor is on contrast, definitely contrast CT urogram. If the patient is the non-muscle invasive bladder tumor, your treatment is TURBT or transmural resection of the bladder tumor. And if it is muscle invasive bladder tumor, then your treatment is radical cystectomy with ileal conduit or something else. Or in case of TURBT, after getting the histopathology, if this is high grade tumor, then you will have to give the BCG vaccine schedule, and if it's the low grade, then you will have to give the intravesical mitomycin, right? These are the immunotherapy and chemotherapy. So these are the things. Okay, let's come to the from the very beginning of the history taking. Dr. Suleiman, could you tell me what are the mistakes that have been done by Dr. Marufa?
I think that the sequence he may lost some sequence for the asking the question.
Okay, you want to only notice the sequences, right? Okay, Dr. Marufa, could you tell me what are the mistakes that you have done? Can't you, sister?
Yeah.
Okay, okay, doctor. Just I'm
You are
telling
the
you.
boss. You are here.
I'm just telling you
Find
the
out
mistakes
our
you have.
mistakes.
You have the mistakes. Always remember, I already mentioned you that history taking and the procedure stations are the main stations to have your whole mark, almost 36 or 37 marks out of 40. These are the your trump card stations. So you did well. I won't say you couldn't perform the stations. You was performing the stations well, but the main culprit, that is the time. That is the time, and time is the most dangerous culprit in the history taking station. And I was looking at my phone's clock, and I have noticed that You took almost 3+ minutes only break break the break the problem. Almost 3+ minutes only to break the problem. But breaking the problem, your questions are fixed. When did you just notice the bleeding? Is it gradually or suddenly? Is there anything that makes your condition worse? Is there anything that makes your condition good, improve? Have you noticed any blood from any other things, any other orifices? These are the fixed questions, six. These are the six. Whenever the in history taking station, whenever patient will ask any problem, just you will have to the first function of you just will have to break the problem. So by asking 6 or 7 questions, then break the problem. Then come to the next station. Next point. Next point is I always would say whenever you will find in your question paper that blood in urine, your diagnosis is definitely bladder tumor. That won't become upper tract TCC, upper tract transitional cell carcinoma, RCC, or anything else. Never, never, never that will gonna be happen other than bladder tumor. So your diagnosis fixed. So don't try to become so much smart. That's I mentioned in our last offline mock. I mentioned that most of our fellow colleagues, fellow seniors and brothers become failed in this type of exams because they do have so much knowledge and they always try to apply this knowledge in the Royal College of Surgeons. But always remember, whenever you will find blood in the urine, your diagnosis is bladder tumor. It won't never be a RCC or upper tract TCC, transitional cell carcinoma. So your first job is to break the problem. At first, you have to break the problem, and second job is to, as your diagnosis fix, so you'll have to fix 4 or 5, maximum 5 differentials. So try to mention the second within the first or second differentials. Your diagnosis try to mention within the first or second differentials. So what are the differentials that comes in your mind after having blood in the urine? The differentials might be urinary bladder tumor, or any stones or BP, or any coagulation or the abnormalities or something else. The problem why we get blood in our urine. So you'll have to fix 4 or 5 differentials. So try to bring the diagnostic differentials within the first or second one. So you'll have to do this thing at first. So always try to bring the differentials at first one or second one, because you know your stage what your station is going to be. Then bring the another stations. So try to complete your questions within the four differentials. So or maximum 5. Don't try to become so much smart. Don't try to exclude 7 or 8. These things are really unnecessary because your time is fixed. So uh, you'll have to remember. So Dr. Bubli did well, but whenever Dr. Solomon was saying he's smoking or something else, that Dr. Bubli said that's great or something else. But always remember, whenever patients say anything that is not helpful for the patient, or whenever patients say about his sufferings, or he is not his life is in danger, so you can't say that's great. So if in case so patient's
No,
personal
bhai, I said in case of
no, you said
that
somewhere.
he had no problem with the urine stream.
No, in any point, just I will give the
So I
record.
said
So, judge yourself, because you said one point. That's great. So, you repeated 2 or 3 times
yes, I
the
told.
question.
Okay.
Is there any way? Is there any orifice you have noticed the blood? You ask this question 2 or 3 times, and always remember, in case of bladder tumor, though our conventional books did not written this way, bladder tumor always the patients will have total, gross, episodic, and amorphous. These are the diagnostic diagnostic complaints of the urinary bladder tumor. The bleeding will be total, that will be gross, that will be episode, and the shape of the clot will be different. So these are the four things we'll have. As I am from the urological background, the four words you'll have to include in your answer script, right? So you couldn't.
Brother, would you like to say something about amorphous, please?
Different shapes, different size and shapes, different size and
Okay.
shapes. So
The clot size or clot shape is different.
yes, that's the answer. So Dr. Bubli did very well, but I request Dr. Bubli to practice again and again and again, so that she can cover everything in time. So she did very well. Thank you, Dr. Bubli.
Thank you, Bhaiya.
Okay. Okay, Dr. Bubli, we do have second history taking station. So who was for this station? Who was for this station? Yes. Who is this? Oh, Dr. Nashid. Yes, Dr. Nashid. Okay. She is a pro student, pro doctor, and in every single aspect. Okay, Dr. Nashid, is there anyone who wants to become the patient? Is there anyone who wants to become the patient for this station? Isn't there anyone? Dr. Solomon, would you like to become the patient?
I'm sorry because I'm not prepared for this station.
Okay,
I'm
okay,
so
no
sorry.
problem. Okay, no problem. Okay, to finding the mistakes, being a patient is quite difficult. So let's start. Dr. Nashid, I'm becoming the patient. You do have 1 minute to read out the question. After that, we'll start. Are you ready, Dr. Rashid? Your 1 minute is up. Let's start.
Hello, good morning. This is Dr. Nafis, another surgical doctor.
Good
I
morning.
confirm in numerology.
I'm Mr. John, 34 years old.
Hello.
Yeah, 50 years old. Yes, I'm Mr. John, 50 years old.
Hello.
Can you hear me, Dr. Nashid?
Hello.
Can't you hear me, Dr. Nashid? Hello, guys. Can't you hear me?
Yes, we are
sir.
hearing very clearly.
Dr. Nashid, are you there? Hello, Dr. Nashid. Are you there, Dr. Nashid? I think her network is not working. Just wait for a while. If she doesn't come in time, then we'll start another station. Is there anyone who wants to participate this station, pulmonary embolism? Is there anyone who wants to participate? Why, guys? Why don't you want to participate? If I got this type of platform, definitely I would participate again and again because we are very much experienced. I have already told you. I'm here to find all of your mistakes. Isn't there anyone who want to participate? Then, if no one, then we will shift to the next station. Okay, Now come to the next station. We'll come back to this one if Dr. Nashid come again. And this is the person communication. And before starting the person communication, I would like to mention one thing, guys. This is the station. This is the person station that I haven't heard in my whole life for the last 2 to 3 years, from where I am attached with the MRCS Part B exam and preparing for the exam. I haven't anyone who have told me that his communication was become very bad in the exam. I haven't heard from anyone. Everyone said his communication was quite good or this okay, and that was very well. But I haven't heard from anyone who said his communication was bad. The only reason, what is the real scenario is, in the person communication, there is two rooms, this one and this one. And this room is for the preparatory station for your preparation, and this one for the performance. Performance, and this one is the preparation. So you have total 10 minutes here and 10 minutes here. 10 minutes here. So in front of the door, there will be written that there will be written is short hints that we are going to have a communication scenario or file inside the room. So after 1 minute to read out the question, you will enter into the room, and you have 9 minutes to prepare the whole scenario. In the table, there will be um, 10 or 12 pages will be kept there, and so many type of handwritings. There are so Italian font, there are so handwriting form, there are different types of handwriting will be written on the papers. So these things will make you so clumsy. There will be so CT scan reports. So there will be some blood, complete full blood count, serum creatinine level, electrolytes, and a scenario how accident happens. These things will be written in the case file. So you'll have to prepare the case file within 9 minutes. Then we'll enter. After 9 minutes, you will come this in front of this room. So you will get 1 minute to read out the question here. Then we'll enter into the room. So interior of this room is this room. There will be table here. There will be chair here. One chair is here. Another chair is here, and another chair is here. So after entering the room, this is the person you are, and you enter into the you come into this point, and this one is surgeon, and this one is layman examiner. So as you are practicing today, I know all of you know what is the role of the surgeon and what is the role of the layman examiner. So surgeon will ask you, are you prepared, doctor? Yes, I am prepared. So he will say, this is your patient. Now start your station. So this is the patient. So this is the only thing that the surgeon will talk to you. Nothing else. For the rest of the station, surgeon won't say anything, not even a single word he will utter with you. So every single doctor who appear in the Part B exam, as they don't have to encounter the surgeons or the teacher or any questions from the surgeon, the exam becomes well, because they only do have to encounter the patient, and patient is only to acting. He's not to judge you. He will answer you how he has already been taught, but this two-person will monitor you silently. So whenever you talk to anyone in your exam, they will say that their exam was good because they don't have to encounter any questions. But ultimately, when the result come, you will come to know the uh, mark sheet. These stations become so dangerous, and the patient or the examiner will get a poor mark from the stations, because these stations are very tricky. You will have to very much expert. You will have to very much smart how to deal the patient, how to show the empathy, how to fluctuate your voice, how to nod your head, when to smile, and how to build the rapport with the patient. So always practice this portion because you do have only seven stations, but you will have to practice again and again, and you will have to become a pro level type of performer, because MRCS OSCE exam is a stage of performance, nothing else. Did you get it, doctors? Hello guys, did you get it?
Yes, brother.
Okay, okay, that's great. Okay, so this sessions was for Dr. Sabrina. I hope she's
Yes, doctor, I'm here.
yes, she's from the very beginning of the class today. And in your real exam, you will get 10 minutes to perform this to preparation, but for lack of time, you will. I'm giving you only 2 minutes to read out the question, and Dr. Bubli is here, and he will be the patient. Are you here, Dr. Bubli?
Yeah.
Okay.
Yeah.
So be a cool patient because it's a cool station. So Dr. Sabrina, you have 1 minute to preparation.
Okay, doctor, can you mention my patient's name, please?
Okay, this is a outdoor patient, so you'll have to ask the patient's name. So in case of indoor patient, you don't have to ask the patient, but whenever the patient is outdoor patient, you'll have to ask the patient's name and age.
Do I have to ask the patient as I have already the papers and I should get the name from them?
No, you
the
don't
previous
have to.
investigations.
No, if that is
Okay.
in most of the cases there, because in case of OGD, so many things won't be given in your exam. In case of subcapsular hematoma, this type of things in indoor patient, you will get so many papers. But this type of OPD type of patient, you won't get that much papers. So you are allowed to ask the patient name and age. No problem.
Okay.
This is a very common station. You rapidly this station very commonly comes in your exam. So have a very well preparation, and you will learn so many things from this to participant. Just tell me when you are ready.
Yes, doctor, I'm ready.
Okay, just let me set the timer. You will have 9 minutes to start the. Your time is start now.
Hello, good evening. I'm Dr. Sabrina, one of the surgical doctors here. Could you please mention your name and age, please?
Okay, I'm Miss Queen, 37 years old.
Nice to meet you, Jane. Today I've been asked to talk to you about an investigation we want to arrange for you. But before that, could you tell me how far do you know about it?
Oh, doctor, I know nothing about it. No one has spoken to me earlier about this.
Okay. Oh, okay, Jenny. Then let me tell you about it. This is what we call esophageal gastroendoscopy. In abbreviated form, it is OGT. So here is a camera which we called endoscope. This is flexible, of course, and this camera will be inserted through your mouth and down to your food pipe, and then your stomach, and lastly along the first part of your small bowel. So the camera, this will show us the image of your inside, so we can have a look inside. So far, do you get me, Miss Jenny?
It's really very difficult for me to understand.
Yes. So let me show you some image. I should show you this by drawing some pictures. Okay. So here is your mouth. This camera will be a size of your finger. Thin would be the finger, and this will be inserted through your mouth, and this will come down to your food pipe, and then stomach and small bowel. Okay. And by this camera, we can look inside what's happening there. And also, as the previous investigations showed, there is a narrowing of your food pipe. So we would like to dilate it for you, okay? And also take some sample from the lining of your food pipe. Do you get me, Miss Jenny?
Yes, I got you. But is there any risk, doctor?
Every procedure has some risks, Miss Jenny. In this procedure, you can sometimes during entering the camera, your teeth can be damaged, or sometimes you can get some infections like chest infections. Also, when we're gonna take the sample, there might be bleeding. But the most risk there would be when there might be uh, you know uh, uh, the lining of the food pipe can be teared up, and this will be the most risky part, and we have to manage it in operating field then.
Okay, there are a lot of risks, doctor. I'm so much worried about this, and I'm not going to do it.
I understand, Miss Jenny, but let me tell you, listing all the risks doesn't mean this will happen necessarily, okay? And this procedure will be done only by our professionals and experienced hand. So you don't have to worry much. And I'm stressing about this because you need to be diagnosed, and this investigation will be so helpful for us. And also about the risk you're saying, we have expert panel and they can tackle it very much professionally. So don't be worried, Miss Jenny.
Okay. As you said that it is important, then I can have it. Can you tell me why am I salivating too much nowadays?
Yes, that might be a reason because of, the previous test we said about the barium imaging. There is a narrowing of your food pipe. This is hindering your normal flow of salivation, down to your food pipe to stomach. That might be the reason you're salivating regularly nowadays. You get me?
Another thing, yeah, I got you. Another thing that is I'm worried about that is it cancer, doctor?
Oh, Miss Jenny, this is too early to talk about it. This investigation is for that. After coming the result of this investigation, and also we might have to do some more investigation so that we can get down to the possible diagnosis. So this is too early, I should say.
Okay, and when the result will come?
This kind of procedure, it takes 2 weeks of time frame, but I get your apprehension, so I will try as soon as the result come. I will contact to you.
Will I need to be
do you want to
admitted?
know?
Will I need to be admitted
Yes, tell me.
in the hospital for the procedure?
This is nothing I should say like that, you'll be discharged after when you wake up. You'll go under a sedation for this procedure, so you might feel a drowsy, and after when you wake up after maybe 2 to 4 hours, you can be discharged. But next 24 hours you can't drive, so you need someone to drive you home safely.
Okay, doctor, one more thing. May I have this procedure under full anesthesia or something like that I read in internet?
Yes, you can have, but full anesthesia is much more, I should say, a critical procedure, but rather than a sedation might be very good for you. So, and after 2 to 4 hours, you will wake up and you can be discharged home. But if you get full anesthesia, so we have to keep you in monitoring. So I will suggest you should think about sedative more than full anesthesia. What do you say? You want anything more to say?
Okay, not now. That's
okay. So let me sum it up for you. Do you want to hear it about it? So Miss Jenny,
yes,
we want you to have this investigation, what you call OGD, esophageal gastroendoscopy, and this will be done under sedation and by our expert team and also a professional doctor. And I have listed you all the risk and also about the importance of this investigation you have to do. And after that, I should say I should say you have to sign a consent paper if you agree. Do you get me, Miss Jenny?
Yes, I get you.
Okay. So here is the consent paper. You could sign it for us, and we are all here to help you, support you, and dive your hand anytime. Okay, and I would give my contact number to my nurse, and if anything you need, you can get contact number and contact me at any time, and I am always here for you.
Okay,
You
thank you,
understand? Thank you for your understanding, Miss Jenny. Dr. Rifat, I think we are done.
Are you done, Dr. Sabrina?
Yes, doctor, we are done.
Okay, I would like to go to Dr. Bubli at first. What's your comment regarding Dr. Sabrina Rahman?
Yeah, she's superb, and I'm a student. I don't see anything wrong. You are the teacher. You will
No,
see
no.
more every corner of our talking that there is a mistake.
Okay, no problem. One thing, Dr. Sabrina, regarding Dr. Sabrina, she did really well.
Thank you so much, Dr. Bubli. Your comment is very much inspiring for me. Yes, Dr. Rifat, go on.
Yes, regarding your performance, I would like to say that your timing, your way of speaking, especially the rapport build up and your tone fluctuation, everything was really, really, really good. But few things you have done few mistakes here. I will comment eventually. But regarding some questions, but at first you did really well. Your rapport build up and everything was good. So your communication is really up to the levels. Just you will have to know the proper thing, what to say basically, because you did few mistakes and the real answer was not like you are saying, but the web communication was really good and your timing was 9 minutes and 30 seconds, and that was really good. So guys, one thing I would like to say, in communication station, if you want to finish the communication within 5 minutes, that is possible. And if you want to run the communication for the 8 or 9 minutes, it is also possible. So if you answer the questions or present the thing very palatable to the patient, and your effort is up to the level, then it will take 8 to 9 minutes, because all the questions are set by this way. So don't try to finish the communication station within 5 or 6 minutes. I would suggest you minimum take 7.5 minutes or 7 minutes and 30 seconds to finish your communication. So your timing was really good and your communication skill was good. So first come to the few more things that in your case, you talked about the barium X-ray, right? So what did you say?
Imaging. Yes,
What did you say?
I said about the narrowing of your foot pipe, what we found out earlier in barium image.
Okay, in that case, always remember a question in your table, there will be paper and pencil. Always be present here. So when you will say about the patient that, okay, Mr. Dr. Bubli, this is your mouth, this is your food
Foot
pipe,
pipe.
this is your stomach, and this is your small part or first part of your small bowel. So we'll insert into a flexible scope through here, and that will be run into the foot pipe. And I have already mentioned you that you have a narrowing in your lower portion of the foot pipe. So there will be camera is set in front of the flexible tube, and there is a TV set which will relay the real situation that's going on, that will be
Yes.
relay in the TV camera. So
Yes,
what's
I
the
get it.
purpose?
I forgot to, yes,
So
I
what
forgot
is the
to mention
purpose
about
of
the
the
TV screen and relay.
what's the purpose of keeping a paper and pen in the table? So definitely it has some purposes, right? So you will have to
Yes.
answer by this one. I would always recommend you, in case of person communication, you do have you there is so many things you will have to do, because if you can do this thing, you will gain definitely so many marks, right? So we'll discuss those things eventually station by station. So one question Dr. Bubli asks about that: will the procedure will be run into a full sedation or sedation or anesthesia, full anesthesia? So what
Yes, she asked for, could it be done under full anesthesia?
okay, so definitely it won't be done under full anesthesia. The patient will give some sedation like midazolam or something else, so that will run. But in case of any benign stricture, if there is any benign stricture, the purpose of OGD also to dilate. But in case of dilatation, you can't the dilatation into a deep sedation. So if you change your mind, so if you do have a plan to dilate the food pipe, then we'll have to keep the patient into a deep sedation or general anesthesia. Then we'll only allow to do the procedure, right? So
Yes, yes.
one thing at the end of the
Is it that I can discuss it with my anesthesia colleague and my consultant, that is it
yes, yes,
possible
yes,
or not?
yes,
Is
definitely.
it like that?
If you think that there is a
But I am
don't
not going to give the opinion.
yes, 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 you are not going to give the opinion. And another question, will the patient stay in the hospital? Dr. Sabrina said something. What was your answer?
I said after you waking up, around 2 to 4 hours later, you can go home, but you cannot drive the next 24 hours, so you
So
need someone to drive you
what's
home
between
safely.
the 2 hours, 2 to 4 hours? What will she
I
do?
said about the waking up. After waking up,
So
the
will
sedative
she
may
be
work
kept
for 2 to 4 hours.
will she be kept into the procedure bed without having any observation or something?
Yes, she'll be under observation.
Okay. After having the procedure, she will be shifted into the observation room.
Observation.
Right.
Yes,
Always
yes.
remember this thing really will be asked into exam. So as the patient, a recent occurrence in our Bangladesh in Levid Hospital, the patient was given midazolam and patient ultimately died, right? He's always or something else, sleep apnea or something else patient had. So don't forget to mention that after having the procedure or finishing the procedure, patient will be kept into the observation room. Then after observation, when patient wake up and it will take 2 to 4 hours, then he only then is allowed to go to his home. And always mention that someone to accompany him, because he is not allowed to drive the car.
Able to drive.
So always try to mention this thing, right?
Okay.
So at ending, you
One more
mentioned that at the end of the conversation, you mentioned Dr. Bubli that or the patient, if you feel any difficulties, I will leave my phone number in the nurse. But in our conventional book, this is given phone number, but I don't know whether it is no or not, because giving the phone number to the patient is in UK is highly prohibited. So
Okay.
always ask the patient if any difficulties arises to come to the emergency department or somewhere else, or you can you come to know that the doctors have some bleep number, some kind of walkie-talkie is kept with them. So these things are called bleep number. So you can say bleep number will be given here, so you can contact with me, right? So these are the few mistakes, but I think your communication was quite good and really good. Just try to answer the thing correctly. That's all.
Could I get a pass mark, Dr. Rifat?
Yes, definitely. All of you have passed in the in the station. So guys, thank you very much for the full cooperation. I am in front of you, and this is
Thank you.
our course details about course, and I can see maximum of our participants today are my ex-students, because I am teaching for the last 4 and 5 years, and so many sectors, FCPS, residency, MRCS, and not, and every single aspect I have a great experience to teach everyone. So this is our course curriculum, and this time I have so many students who have passed in the MRCS Part A exam, and they are just asking me, Bhaiya, when will you start? When will you start? And I was really worried that I am not able to start because I was so much busy then, and I didn't get the guts to start the course. But right now, with the help of one of my most favorite students and younger brother, with the help of him, I have decided to start our course. And always, I would like to say, this is the first course. These are the exclusive portion. You could know there are some offline mocks, and with the complete support and the most updated books will be provided it you. And one thing, this is the maximum, almost you can see these are the 70 class plus this 5 plus, almost 75 plus, and so many other classes have been included, and the course fee within a limit. And I always want to say finance or won't be a obstacle between us. So if you wish to join with us, and we'll hopefully start our course within 24th of this month, and I will take your responsibility so that you can pass. I will just show you how to pass the exam. You will have to just follow me blindly. So thank you guys. If there any suggestion, if there anyone who want to say anything, guys.
Okay, Dr. Rifat Bhai, you have thank you very much for your this kind of effort to
No
us,
problem.
and please keep updates for us that
As far
we are able
as far
to
I can
make a
remember,
pass
you
in
are
the.
from my FCPS batch, you are from my MRCS Part A batch, and everywhere you are, right? Dr. Sulaiman.
Yes, yes, brother. I'm following you from very first of my career, post graduation career.
Okay, no problem, no problem. So I am here to support you guys. So if you need any suggestion, if not, it's not necessary. You will have to become our co-student. I would, all of you know all of you know me very well. I'm not that kind of professional person. I won't demand so many, apply so many financial burden on you. But this is the minimum cost with the maximum support I can say you. So thank you very much. Is there anyone who want to say anything? Dr. Buble, do you want to any give any comment regarding today's course, today's mock session? I think she is not here. Is there anyone who want to say anything? Okay, okay, guys. If you don't, then I can finish here. And if you want to give a review of today's mock, I will be very much grateful to you. So you are requested to give a review of today's mock in our group. Thank you very much. I will be very much grateful to you. Thank you very much. May I leave today?
Thank you. Assalamu.
Okay. Walaikum salam. Have a nice day.